For a younger patient presenting with early medial compartment osteoarthritis and a body mass index under 30, the underlying pathology is often a mechanical deformity in the proximal tibia. The medial cartilage absorbs asymmetrical, heavy compression with every step, while the lateral compartment remains largely unengaged. High tibial osteotomy, or HTO, addresses this structural imbalance directly. The primary biomechanical objective is to shift the weight-bearing load away from the diseased medial compartment and transfer it over to the healthy lateral cartilage. Correcting the global mechanical axis to make the leg perfectly straight is mathematically simple, but operating solely on global alignment is biomechanically insufficient. A global varus deformity can originate in the distal femur, the proximal tibia, or a combination of both. Ignoring the specific anatomical source of the malalignment guarantees an imprecise surgical intervention. Treating a complex anatomical deformity as a simple global alignment issue leads to clinical failure. Successful load transfer requires a precise, localized mathematical approach that targets the specific bone responsible for the deviation. This diagram illustrates a lower limb where the overall mechanical axis is perfectly straight, but the knee joint line itself is tilted at a severe angle. This represents joint line obliquity, the primary complication of poorly planned osteotomies. If a patient has a deformity originating in the femur and a surgeon attempts to correct the entire mechanical axis by cutting the tibia, the joint line is forced into an unnatural tilt. This induces massive shear stress that rapidly degrades the remaining healthy articular cartilage. Avoiding joint line obliquity requires an isolated metaphyseal-specific deformity analysis prior to planning any surgical cut. A successful high tibial osteotomy requires decoupling the global leg alignment from its local structural components. The surgeon must isolate the exact degrees of varus located specifically in the proximal tibia before touching a saw. The first requirement for precise analysis is a weight-bearing long-axis radiograph. Capturing the leg under active load is the only reliable way to measure true intra-articular wear alongside the bony deformity. The digital planning sequence treats this weight-bearing image as a dynamic coordinate system. It begins with precise size calibration to ensure digital measurements translate to millimeter-accurate physical cuts. Digital nodes at the femoral head, trochanter, condyles, plateau, and talus quantify a 5-degree global hip-knee angle varus. Local mapping finds an 88-degree mechanical lateral distal femoral angle, confirming a normal femur. Finally, an 83-degree medial proximal tibial angle isolates the primary deformity. By mathematically confirming the entire deformity is isolated to the proximal tibia, the surgeon proves that a tibial osteotomy will correct the leg's weight-bearing axis without inducing shear stress or joint line obliquity. With the anatomy mapped, the next phase of planning determines the exact coordinate where the new load-bearing line must pass through the knee joint. A perfectly neutral, centered mechanical axis is insufficient. To actively protect the damaged medial cartilage and alleviate pain, a slight overcorrection toward the lateral side is required. The Fujisawa point provides the exact mathematical target on the tibial plateau to anchor this postoperative weight-bearing vector. This top-down tibial plateau view illustrates the consensus for load transfer. Measuring the plateau's total width places the ideal Fujisawa point exactly at the 50 to 55% medial to lateral coordinate. A new Mikulich line is drawn from the femoral head, intersecting precisely at this target. Identifying this specific target coordinate locks in the surgical objective. Every subsequent step in the procedure is dedicated to maneuvering the lower leg to align with this single vector. The Miniaci method approaches this realignment as a geometric exercise in rotation. It calculates exactly how far the distal aspect of the leg must shift to meet the new Mikulich line. The osteotomy hinge anchors at the proximal fibular head. The software maps the ankle's native position relative to this hinge, then projects its future position to align with the Fujisawa vector. The angle between the native and projected ankle positions dictates the exact 9.2-degree correction. The Miniaci geometry successfully abstracts a complex full limb realignment into one definitive rotational value required at the tibial hinge. In the operating room, it is nearly impossible for a surgeon to accurately measure a 9.2-degree global axis shift by eye. The digital software must convert this abstract global rotation into a localized physical measurement at the exact site of the bone cut. Following Miniaci's rules, the cut is plotted at a 110-degree angle from the lateral tibial cortex, preserving bone stock. A virtual simulation opens the medial cortex along this cut by the calculated 9.2 degrees. This rotation translates to an exact 10 mm linear gap. The entire network of algorithms and biomechanical derivations culminates in a single, highly actionable intraoperative metric, a 10 mm surgical wedge. When surgeons manually plot these lines on raw X-rays, human error in landmark placement introduces significant inter-observer variance. A comparative study analyzed the accuracy of semi-automated software planning against manual measurements across a cohort of varus knees. To verify the precision of the two-dimensional planning, researchers utilized three-dimensional computed tomography scans as the absolute geometric gold standard. This scatter plot compares manual variance versus semi-automated variance. The semi-automated digital planning, utilizing defined landmarks, achieves near-perfect correlation coefficients compared to the 3D CT baselines, while manual plotting shows wide scattering. Standardizing the mapping of landmarks digitally eliminates the human variance that historically caused overcorrection or undercorrection in osteotomies. The workflow requires strict sequence: mapping the metaphyseal anatomy, defining the 50% target vector, calculating the Miniaci rotation, and deriving the exact wedge width. Adhering to this rigorous sequence is the only way to successfully shift the load from the medial to the lateral compartment without violating the horizontality of the joint line. By treating preoperative planning as a strict geometric derivation, surgeons guarantee that every degree of planned alignment translates flawlessly into structural, clinical reality.